and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamigan. Understanding the journey patients living with autoimmune disease experience as they're seeking a diagnosis and ultimately receiving care is crucial to being able to improve outcomes in autoimmune diseases. The manuscript we will discuss today is Clinical Presentation, Care Pathways, and Delays in Access to Specialized Care in Patients with Systemic Lupus Erythematosus, a study from the Lupus Midwest Network, Lumen. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures can be found in our show notes from today. I'm thrilled to be able to discuss this manuscript with its first author, Dr. Elaine Sanchez-Rodriguez. Dr. Elaine Sanchez-Rodriguez is an internal medicine and rheumatology specialist and clinical investigator currently practicing at the American British Cowdray Medical Center in Mexico City, where he coordinates research for the internal medicine department. He completed his medical specialty training in internal medicine and rheumatology in Mexico City, and from 2021 to 2024, he served as a postdoctoral research fellow in the Division of Rheumatology at the Mayo Clinic in Rochester, Minnesota, within the Lupus Clinic under the guidance of Dr. Ali Duarte. His research focuses on systemic autoimmune diseases and disparities in care delivery. Dr. Sanchez-Rodriguez currently serves on the American College of Rheumatology Guideline Committee for Lupus Care and is a strong advocate for improving equity in rheumatology across Latin America. Welcome to the show, Elaine.
Thank you, Vicky. Thanks for that introduction. It's a pleasure to be here and to share this work with you and your listeners. The journey to diagnosis and care in lupus is often long and fragmented, and our study tried to unpack some of that complexity, indeed.
So let's start by talking a little bit about Lumen, the Lupus Midwest Network. Tell us what this network is. When was it established? Who funds it? And how is it supported?
Well, certainly. Lumen is a population-based registry that launched in 2015 as part of the Rochester Epidemiology Project, the REP. This is a long-standing medical records linkage system covering about 27 counties in the southeast Minnesota and southwest Wisconsin. It is a collaborative initiative led by Mayo Clinic, working alongside with other regional healthcare providers to grant access to a very big amount of data within that population. What sets Lumen apart is ability to capture the entire spectrum of care for patients with lupus. We managed to capture everything, starting from the very first symptom seen in primary care, all the way to specialized in rheumatology evaluation. This helps a lot to reduce many biases, particularly referral bias, and provides a very accurate picture of how lupus is diagnosed and managed like in real-world settings. The project itself is funded through the cooperative agreement with the CDC, and the REP infrastructure allows us to follow patients longitudinally from symptoms onset through diagnosis, treatment, and the long-term outcomes.
And why is it so important to look at care pathways for people living with lupus?
Well, this is a very good question because lupus doesn't present the same way in every person. This condition is very highly heterogeneous, both from the clinical but also from the sociological point of view. For example, some patients have skin rashes or joint pain, others may have thrombosis or cytopenias, and these differences impact how and when the patients seek access to care. Understanding care pathways help us identify gaps, especially delays that can lead to damage or worse outcomes. If we can shorten those delays, maybe we could improve long-term health for those patients. Yeah.
So as you mentioned, Lumen is a population-based registry, a cohort study of patients with incident lupus. Because of the way the study is structured, you have access to clinical data predating the diagnosis. So it's a very valuable and rich resource, but it's also a unique geographical snapshot of healthcare in the United States. Tell us a little bit more about the region from which these individuals were drawn and the demographics of the patients included in this analysis.
Well, yeah, this was a fairly large community-based cohort. We now are holding data for about 373 patients with incident lupus, but the whole region covers about the information for about 500,000 people, and we have very accurate data from that regional and healthcare slice of the US. And yeah, most of the patients from the study, as it is in SLE, is about 80%, And the average age of presentation, at the time they fulfilled classification criteria, was about 43 years. The majority of participants were non-Hispanic white, although the cohort includes individuals with ethnicities identified as Hispanic, Black, and Asian, which reflects some of the diversity within the region. These patients were drawn from the 27 counties in the southeast Minnesota and southwest Wisconsin in an area served by the RED project. This region includes both rural and semi-urban population, and it is unique as it allows to access complete medical records across virtually all healthcare settings. We can cover public, private, inpatients, and outpatients, and then give us a very good window of how lupus unfolds in a real-world setting, as we are virtually avoiding any kind of referral bias. Also, we have a very good approach to a community-based setting, which is something that many cohort studies don't capture. It also allows us to analyze patterns of healthcare use and delays without the bias that comes with a study only academic that found in academic centers. We are very susceptible to many types of bias. For example, as I told you, referral bias, survival bias. The REP allow us to do a very, very good clinical picture from these patients from the very beginning through their navigation through the healthcare.
So, how do you define lupus in the population that you're studying? How do you extract and analyze the data? Is it all coded insurance level data, or were there physicians manually abstracting data from this registry?
Well, yeah, this was a very, very, very hardworking process. But we used the 2019 Euler ECR classification criteria to identify and classify a patient with SLE. The whole patients in the cohort fulfilled this classification criteria. So through the resources of the Rochester Epidemiology Project, we had access to all medical records, regardless of the different medical facilities. Data was pulled from medical charts manually, not just billing codes. And each time patients had a manifestation that was attributed to lupus, those were actually manually abstracted by the Lumen team. We were all trained physicians reviewers. This gave us a very detailed and accurate clinical picture because this avoids misclassification that may sometimes occur in claim-based studies.
One of the things you studied was lupus care pathways. Tell us how you characterized and tracked the care of these patients in this real-world setting.
We tracked each patient for the first lupus-related medical encounter. Then we identified the most important milestone in their journey, such as when they first saw an SLE specialized provider, when a formal diagnosis of lupus was given, which is very important because not all the patients had an actual diagnosis, a clinical diagnosis of SLE, even though everybody in the cohort fulfills the Euler ECR criteria, not all of them were given a diagnosis at a certain time point. So, and when the treatment was first initiated, we also looked at the specialty of the first physician involved, which helped to understand the clinical context in which lupus was first recognized. You see, some patients initiate with very mild symptoms, but other patients have a debut with a very complex and severe disease.
So, how many patients did you identify with incident SLE, and what did you find when you studied the different presentations?
Well, yeah, we identified 373 incident cases of SLE from this study. Although the Lumen registry includes both incident and prevalent cases, we focus specifically on incident cases, those newly diagnosed during the study period. Those patients we were able to trace their whole story, starting from the very beginning until they fulfilled these milestones in their access to care journey. So we could accurately assess the pathways from first symptoms to diagnosis and treatment. When we looked at clinical presentations, the most common first manifestations were hematologic abnormalities, followed by musculoskeletal symptoms, for example, joint pain, arthritis, and mucocutaneous findings, which were about 3/4 or 75% of initial presentations. But a lot of patients only had one single domain involved at their very first access to care, which may explain, at least in part, for those who had a delay in recognition and referral. Because only about 12% of patients saw a specialist during their first clinical visit, because most of them were seen by primary care physicians or by other specialties. This is important because, as you can see, many of them had rash, for example, and cutaneous manifestations. And the most important specialty, the primary specialty that saw patients with this kind of manifestations was dermatology. So, as you can see, it's not like both the manifestations, but also the medical specialties are very heterogeneous when patients have this onset of the disease.
I think that's fascinating and really important for rheumatologists to recognize that the physician who sees patients with lupus first is very often not a rheumatologist. Were there any other gems in that part of the data that you want to share with our listeners?
Well, yeah, sure. Because sometimes patients have a debut with these clinical manifestations, for example, rash, or for example, severe manifestations such as hemolytic anemia or some joint manifestations. But the thing is that sometimes lupus is not like the first diagnosis they're thinking, and this could lead to a delay in a referral. And this is very important because a lot of patients, I mean, about 17% had their first access to care in emergency department, which
Hmm.
sometimes we forget that lupus is a systemic disease. It's not only joints and the skin. Also, patients need to access ED facilities, for example, due to retrosternal pain, due to bleeding, and many other manifestations that are probably not recognized as their first SLE manifestation. Yeah, that's the interesting thing we found because we traced all the way back from their earliest SLE attributed manifestation. And it was very surprising that not all of the patients had this classical picture, of joints and the skin affected at the very first and at the very beginning, right?
Yeah. So, what did you find when you looked at the data on time to access to specialized lupus care? How quickly did patients get to see a specialist, and how quickly did they get medication to treat their lupus?
Well, we found that the median time to access a lupus specialist, whether it was dermatology, or nephrology, was relatively short. It was around 1 month, which accounts for a very large portion of those who were seen by dermatology specialists. However, time to formal diagnosis was much longer. It took about 30 months from the first time patients were seen by any specialty until they had a formal diagnosis. This is not because, I mean, not all of the time it means that the physicians did not or didn't have the ability to recognize manifestations. Sometimes this is because lupus starts with very few manifestations. Sometimes it's only serological, sometimes it's only the rash or the cutaneous manifestation, it's only arthritis. So it takes a while sometimes for the clinical picture to pop up and gives you like the entire spectrum of clinical features, right? So the thing is that this showed that patients took about 5 months to receive treatment. This is very interesting because many times, if a patient debuts with rash, with arthritis, with hemolytic anemia, they will receive immunosuppressors very early, even though they still don't have a diagnosis because the cases treatment is needed, right? So sometimes wouldn't wait until the patient has like the full picture. So we found that many times patients receive treatment before they have a formal diagnosis or before the elements to diagnose lupus were all present, right? Especially those with very severe disease. So we are now interested in this because now we know that treatment sometimes is started like empirically, right?
Mhm.
If we didn't do so, right, this could lead sometimes to irreversible damage, which sometimes justifies why patients receive treatment before diagnosis.
Yeah, interesting. So, what did you see when you looked at the care pathways for the patients who presented as inpatients compared to the patients who presented as outpatients?
Yeah, we were able to notice some differences. For example, patients who first present as inpatients were typically those who had a more severe disease, sometimes affecting serosal, renal, or constitutional symptoms. And their disease activity scores, measured as SLEDAI scores, were significantly higher compared to those who were seen initially as outpatients. This is because the acuity or of their presentation, these patients were more likely to receive earlier diagnosis workup and quicker initiation of treatment. In fact, even though the time to access specialist care was kind of similar, the time to formal diagnosis in those who receive inpatient care was much shorter. This likely reflects the urgency and the intensity of patient evaluations, sometimes by multidisciplinary teams when patients are admitted, right?
Yeah.
And we believe this multidisciplinary approach makes that lupus comes earlier in the differential diagnosis, right? Because sometimes they're seen like simultaneously by nephrologists and dermatologists and everybody involved in care. These care teams are much more likely to come up with a earlier diagnosis that isolated consultations in the outpatient care.
Yeah, no, and I mean there is something to be said for that in the real world, that bringing the patient into the hospital and getting all of the consulting teams communicating together is one of the beneficial things about an inpatient hospitalization that's really challenging to do in an outpatient setting. You also conducted a bit more of an in-depth analysis of the individuals who experienced delays in lupus specialized care. What did that show, and what can that tell us about reaching our lupus patients sooner?
Yes, we found that very striking. One in each four patients had a delays. I mean, nearly a quarter of them had to wait 6 months or more to get access to specialized care. Interestingly, those delays were more common in patients who initially had hematologic abnormalities, antiphospholipid antibody manifestations. And sometimes we believe this is because those manifestations, sometimes if the patient had, for example, a thrombosis, but in an isolated pattern, or maybe cytopenias, for example, anemia or leukopenia, but isolated clinical picture, sometimes it's not like the first thought to the clinician to believe in the patient had lupus. But it was important not only because of these manifestations, but also because patients with delays were these delays were strongly associated with early organ damage, as measured by the SDI score. We measured the SDI score up to the time patients had access to this first specialized care visit. And those who had a delay, I mean, this is a very logical conclusion, but those who had to wait more had time to accrue more damage over the time, right? Because they had a longer period before they were assessed by the specialist in order to get access to a specialized treatment and a specialized care for their lupus. And well, this is very important because needs to underscore this need for broader clinical awareness of atypical and less obvious manifestations of these clinical pictures that could be related to lupus.
Yeah, no, that's really interesting. And I'm kind of wondering, Lumen is a population cohort. It's an area of the US that's served by a fairly prominent tertiary or quaternary care center. How do you think these findings are going to be more broadly applicable to other US populations and even to populations outside of the US?
Well, yeah, that's a great question. I do think many of the patterns we observed, especially in how patients, seek access to care with their first symptoms, how these symptoms, how the debut of the disease actually shape the care journey of patients. So we believe this is relevant beyond the region this study was performed because these challenges are not located just in the US, not just in the Midwest, but everybody in many parts of the world may experience these same challenges, right? Especially for primary care physicians that sometimes maybe they don't have the training, the skills, or they don't feel like the same expertise to assess a patient from the very beginning. So we have to keep in mind that things like insurance access, referral system, and specialist availability across the countries may vary, right? So this is this also may be very different, even across the different regions of the US, right? So I wouldn't focus on those aspects, but mostly clinical pictures, I think, are very highly applicable across the world. So, and also we believe that these delays in access to care could be problematic across every healthcare system, not just in the US.
Yeah, no, I completely agree with you. And I'm sure you recognize this as someone who has worked in multiple different medical settings. I certainly recognized it when I moved from the UK to the US. The clinical presentations were very similar. Figuring out how to access the healthcare system was a little bit different.
Yeah,
Um,
yeah, that's why we need to expand this kind of research globally. I mean, for example, there was a very recent systematic review published in Rheumatology, co-authored by a colleague, Tabata Cano and Iris Pelaez, which was a systematic review about delays in diagnosis in lupus. So I think this awareness of how serious and how problematic these delays are for the patients across the world, I think is very important to increase our awareness for sure.
Oh, that's wonderful. And I really enjoyed going on this journey through the Lumen data with you. I wanted to chat a little bit now about how you got involved with this project. You joined the Mayo Clinic in 2021 as a research fellow. How did you come into that role? And how did you get involved with the Lumen project?
Well, yeah, sure. It was back 2021. Dr. Ali Duarte Garcia and the team at Mayo Clinic were building out the Lumen Lab. And they actually put out an open invitation through the Mexican College of Rheumatology. So it was a call for young researchers interested in lupus and access to care. And that's how Dr. Gabriel Figueroa and I got involved back in 2021. At the time,
Amazing.
I was practicing in clinical rheumatology. I mean, I was practicing it in Mexico, but I was also looking for options to dive deeper into research. Especially lupus epidemiology was very interesting for me at the time. So I saw this as an opportunity to strengthen my ability to design and carry out meaningful clinical studies. So joining Lumen felt like the perfect opportunity to get like hands-on in real world data and start exploring some unanswered question about this disease in everyday practice. The CDC grant had a supporting role in Lumen. I think this still does. And they had this particular aim and improving access to care information. But once we started looking at the data, we noticed that some patterns, it was not just the time, it was not just the time it took for patients to receive a diagnosis, to receive treatment, but we actually found that it was a very complex matter in terms of navigation healthcare. And sometimes we see the healthcare journeys was very fragmented. In other words, patients before see a rheumatologist, they see a very broad, a very complex, and very heterogeneous group of specialties and settings, right? So that's when we came up with the idea of care pathways. It's not just the delays, but also the trajectory in healthcare, which seems to be important, right? So this idea, we came up with this with the whole team in Lumen Lab. And honestly, I really felt very fortunate because I had an incredible mentorship by Dr. Duarte, which was like with us throughout the whole process. And we had a great team, a very very collaborative team, which helped us everybody grow as a researchers.
Oh, wonderful story. And do you have any tips for other international medical grads who are looking for research positions, particularly in the US?
Yeah, sure. I mean, absolutely. Please reach out to mentors, show initiative, and be clear about your interests. When I first contacted Dr. Duarte, I didn't have a formal proposal or a detailed plan, but I expressed my willingness to learn. My commitment to teamwork, I think, was very important. And I was ready to be creative and open to carry any collaboration was available for me. So I didn't know the details about the group at the time, but I was genuinely enthusiastic and open to contribute to whenever I could. Also, I think it's important to be honest about your limitations, especially when you're just starting in this research journey, but also lean into your strengths, whether it's a clinical experience, curiosity, or communication skills, showing what you can bring to the table that really matters and could make very good use in a team. And also, if you're applying for a road, you need to be brave and persistent because it's very hard sometimes to be very scary. But if you stay committed and open, you'll see opportunities will come.
Oh, that's really good advice. What other projects did you work on while you were at the Mayo Clinic?
Well, we were involved in a lot of projects back then. During my time at Mayo Clinic, I've been involved in a range of projects. For example, we explored the immune response of COVID vaccines in patients with autoimmune diseases. We followed both antibody responses and biomarker changes over time, which was very relevant back then during the pandemic, right? And also, Colette, I also developed a multi-center cohort study and systematic review on a condition called posterior reversible encephalopathy syndrome, or PRES, in
Uh-huh.
patients with lupus. I mean, this is very rare, but I mean, to date, I think this is the largest cohort ever assembled for this disease. This is still, this is still under review. This is not published yet, but it will be very soon. And most recently, I had the privilege of serving the ACR, Guideline Development Committee, for the upcoming 2025 recommendations for lupus and lupus nephritis. This was very surprising for me because this is a very incredibly meaningful experience. Getting to work with experts in the US and everybody, from many cities and as the US and Canada, helping to shape guidance and really contribute with something that will actually make a difference in the daily clinical practice. It's very exciting for me.
Yeah, really important work. So now that you're back in Mexico, you're back in practice. You're practicing internal medicine and rheumatology. What is next for your career?
Well, yeah, it was about 3 years back in my clinic where my time was devoted almost entirely to research. Returning to Mexico gave me the opportunity to reconnect with clinical practice. And now seeing patients both in rheumatology and internal medicine is now really fulfilling for me because I learned a lot in the US. So I feel very proud to share that knowledge and that insight with my peers back in Mexico. Also, I had the chance to contribute to academical side, supporting research efforts, and as a chair, leading the head of internal medicine department in research. Yeah, as our PIs always said, go back and build a school. So this is a guiding idea for me to help build spaces for collaboration, mentorship, and research. Just this make this greater than us. This is just beyond one person.
Yeah, so go back and pay it forward.
Yeah.
Basically. Yeah, I love it. So, Elaine, I really want to thank you for joining us today. It's great to hear about your work and hear about your own journey. And I'm pretty sure we're going to hear more from you in the future.
Well, thank you, Vicky. It's been a pleasure be here with you and talk about this project and the broader implications for lupus care. And most importantly, I'm grateful to the patients who make research like this possible by sharing their journeys. Their stories actually, guide our mission. And of course, I'm deeply grateful to Dr. Ali Duarte Garcia, who was not able to be here with us today, but also Dr. Gabriel Figueroa Parra and Dr. Cynthia Crosson for their mentorship, generosity, and example throughout my time at Mayo. Their guidance have lasting impact on my career, the careers of many students in Mayo Clinic, and also make a very big difference in the way we think about research and patient care.
Today, we also extend our gratitude to individuals living with autoimmune diseases who are willing to share their experiences and, through research, help improve access to care for those who follow. What a fantastic legacy and gift to the future of autoimmune disease research. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRoom on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.